everyone. Thanks for joining in. Good evening. If possible, do come on video so that we can see
Yes.
you and that we are not just talking to a bunch of boxes.
It would be nice to see everybody for sure.
Thank you. I see one
Thank
video
you.
that's come
Thanks.
on.
So, good evening, everyone. I am Vaishnavi Suresh. I'm a board certified level 2 genetic counselor working with Mapmygenome. It gives me an immense pleasure moderating this particular session. So, today's topic is let's talk about the C of genetic counseling. And we have the most amazing genetic counselors in our country as our panelists, and they would be discussing one case each. So, let me first introduce the first speaker of the evening, Miss Nibby Jacob. Nibby is one of the India's pioneer genetic counselors to have trained and returned to India to set up genetic counseling services and training in the year 2010. She brings to the table an eclectic professional experience of over 12 years in genetic counseling and educating, and is a much sought after expert in the field today. She is the founder of Blue Gene Health Tech Private Limited, which was set up in 2020 to ensure access to patient-centric, ethical and expert genetic counseling services across borders, and is a visiting consultant at Cloud9 Hospitals, Bangalore, Shankara Cancer Foundation, Bangalore, Kangaroo Care Hospital, Bangalore and Mysore, Ms. Ramaya HCG Center, Bangalore, and centers in Singapore and South Korea. She was instrumental in setting up the genetic counseling program at Manipal Hospital, Bangalore in the year 2013, which was a first of its type university certified program in the country. Nibby is passionate about patient rights, educating, and spends a lot of time mentoring students and medical professions. In previous roles across hospitals, NGO, and genetic test providers. In her free time, she actively works towards raising awareness and promotes the practice of ethical and patient centric genetic counseling in Asia, where the field is relatively new. She is published author and has been invited as a speaker for many national and international conferences. She is a member of the Translational Alliance of Genetic Counseling, Asia Pacific Society of Human Genetics, Professional Society of Genetic Counselors in Asia, and Indian Society of Human Genetics. I'm sure all the Indian genetic counselors know all the three speakers already. I welcome you, Nibby. Over to you now.
Once again, good evening, everyone. Thanks for joining in. And Nija, thanks for sharing the slide on my behalf. Move to the next slide. So the reason I decided to present this case is it's something that we all come across very frequently in the clinic, especially in a prenatal setting. And while the intentions of, say, the ordering physicians or whoever's care the patient or the family is under, while their intentions are good, there is a possibility of always finding something that they didn't anticipate or expect. And then once you have this, that's usually when there's a referral that comes in for a genetic counseling session. So here's the case. There's a couple who are consanguineous of Indian origin. Both are well educated and employed as engineers in the city of Bangalore. Their first child, a male aged 4 years, was clinically diagnosed with cerebral palsy. No consult with a clinical geneticist or a genetic counselor. And the wife is currently pregnant. At 13 weeks of gestation, their doctor ordered a prenatal diagnostic test, which was the whole exome sequencing. And this was directly on a prenatal sample via CVS. And the mother is now 28 weeks and referred for genetic counseling after making rounds of multiple doctors. Now, the whole exome result did not reveal anything that would have pointed out to something that the child may have had. No pathogenic, likely pathogenic VUS, nothing found. However, there was an incidental finding of an MSH6 gene, a pathogenic variant. Now, when the patient came to me, Nija, we'll stop at this presentation. Let's not go ahead. So, at this slide. So, when the family came to me, the challenge was the way I described the case, that's exactly two sentences in a note that I received. There's no family history. There is, forget three generation family history, right? There is no examination of the child. There are no medical evaluation reports of the proband in this case. So, what we had to do is not just talk about the genetic test results, but go back and start from the beginning and start with what we would do in a pre-test genetic counseling session.
Mm-hmm.
So obviously this is a session that went like extremely long. We typically take about 45 minutes, but this consult went about 45 minutes, about an hour and a half, not 45 minutes. So now the question is, with this scenario, what all do you think, or what can you anticipate as issues? And the ones that are glaring, there are many. I mean, there's medical management side of it, there's ethical side of it, and there are also psychosocial elements that are so important, right? So we can open up the discussion with Nija, Dipanjana. I'm sure both of you have seen similar cases, right? So what would the glaring issue be here that you would notice and that you would take up?
I think the first that you've likely already pointed, the fact that this is not the right way of diagnosis. Obviously the doctors have the right intention in mind, but um, understanding why there is a need for doing the diagnosis for the proband first, and why that is that's important, how that is informative for the family for a recurrence risk. I think that itself, not having that knowledge, that basic knowledge, and also implementing that, in your practice, see such cases. Second, I think most common issue that you tend to see with these families is that they think that, okay, now that we've gone through the test, is going to give us some information, we can make a decision on the pregnancy, but then they suddenly come to this session and then we kind of break that balloon and say that, no, what, this is actually creating more uncertainty. And we actually don't know what this is, and this is really not informative. And the response to this can be frustrating, to the response being disappointed, or sometimes even in cases where they feel like they've been done wrong. So it really ranges from one person to the other, and it's very challenging for us also to address the psychosocial concept. On the top of that, educating them and helping them understand why testing the proband is so important. And they feel like we're taking them backwards, in many ways. I'll let Dipanjana pitch in with her thoughts.
Yes, the first thing is that, there are three glaring things over here. Number one would be the essence that the test was done without any counseling. Like maybe after counseling, they wouldn't have even gone forward for the test. The second part was the expectation that the test would bring. Obviously, a genetic counselor would have explained what the situations would have been. And the third part is also that, after getting the test, probably they sent to NIBI because the clinician themselves were unable to handle this. So, when they see, for a family like even us, if we have this clinician who is getting clueless, it does not impart too much confidence in the patients. And there, when you are said to, you go to another person where you did not even have an alliance first with that person, because the post-test counseling, the pre-test counseling, we actually establish a bond with the patient. Now, next time when they are coming, it is helping us. Like if I use the exact terms, then actually the first thing, we are establishing a psychodynamic in the pre-test. We are establishing a psychodynamic status with the client, where next time when they come, they are more comfortable. And when we are even imparting a bad news or no news, number one, they know from the pre-test counseling what is there to expect. So if there is a report like this, they are not really worried, or they are not really anxious. And also, second, there is a lot of anxiety which comes in with this. That there can be two issues. One is that, oh, there is no wrong and everything is all right. This is a gene which is unrelated to whatever we are trying to find. So we don't have a problem, right? So that another thing that can happen is that they may completely disengage. They may disengage from you, they may disengage from the clinician, and this patient might be lost. So any further investigations or scope of the trust that patient had is broken. So here two very important things, like if we tend to get these cases, so it's very important, as Nibi correctly pointed out, to take a lot of time, maybe even ask them to come back, maybe not give them like the complete flow of information and say that we need you to come back again for the next set. Also here I would say it is important that if you have a psychologist with you, to put them through a psychologist, because see, if the person is pregnant and they already are fighting a lot of issues, there's a lot of anxiety that is going on around. So my 2 points would be that though we are very much stressed right now at the diagnosis point, we should also understand what a report should do in the next phases. And this is one case which actually highlights this kind of issue, I would say.
Yeah. Thanks for sharing your 2 cents, Nija and Dipanjana. And this is a typical case example that where, instead of focusing on just the diagnosis and focusing on the technical and the medical part, a lot of time actually went into the psychosocial elements in supporting this family through the situation they were in, right? And the second part is we really have to uh, sit with the family and decide what is a priority to them right now. Because when we look at cases and when we look at reports, we think, okay, this is priority, then the next thing should be so and so. But I think this is one of the rare cases, especially in a prenatal setting where time is of the essence, right? Where we try and identify what is a priority for them, why are they here, and what would help them in the current situation, and how can we break down this information. So obviously we cannot look at at 28 weeks of pregnancy, she just has to go through with the entire pregnancy, have the baby, and at the same time they're concerned now about a sudden risk of cancer in the families, and could they potentially, both the husband and wife, be at risk, could the elder child be at risk, right? And you know again, mislabeling a child. So again, the proband was diagnosed as cerebral palsy, and when they came in for a genetic counseling session, they did not bring the child in. And so I had to ask them for photos or videos of the child to see what it was, and the child looked clearly syndromic. So it wasn't a true case of cerebral palsy. And I think where there is no diagnosis, or maybe the doctor is not very confident with the diagnosis, I think all of those children just get categorized into the label of cerebral palsy, right? So those are the things again that we had to reassess with the family, get the family back in. So this particular session, even though it should have been one post-test counseling session, it was split into 4 different sessions at 4 different times, right? So the first time was just the husband and wife establishing what is it that would give them some sense of peace and some sense of answers, right? The whole reason they went into this was to identify something that would help them. And again, there's an idea that, oh, whole exome sequencing, it's a test that looks at just everything. It's an expensive test. So whatever answers there, we would get all of the answers. So I'll just go into the next few slides to show you how we broke it down into medical issues, psychosocial elements, and what are the ethical concerns here. So obviously the first thing was with the sense of what is a diagnosis in the first child. I think that was a clear worry for the couple. And based on that, could there be a risk in the pregnancy, in the ongoing pregnancy? What can be done next? What do we do? And it's about pregnancy management at that point of time. And the secondary would be the proband and evaluating the proband, right? So first thing is, next line of text should have been on the proband and not on the pregnancy directly. The timeline is very important when we are looking at prenatal cases. And because they were already at 28 weeks, they were actually nearing 29 weeks by the time they came in for the session, there isn't really anything that we could do to help in the recommending that they get a serial screening and a routine test done. Now, also with respect to the cancer risk, since both of them were very worried about, concerned about their risk, we gave them the option of undergoing screening as opposed to undergoing a genetic test directly, right? Because again, it means we have to look at the family history on both the father and mother side of the family. So in the first session itself, we said, there are options where if they're concerned about their own risk, these are the options that you have. We can go on to the next slide. So, in terms of ethical issues, this is something I feel we do not place enough importance on. And it is very important because this should ideally be ethical legal issues, because any ethical issues, any ethical possibility in the case, it almost always leads to legal cases. And this is something that we have seen time and again in cases, plenty of cases and examples from the US, from European countries, right? So, one, what are the possible findings from whole exome, the expectation versus what has actually happened, right? Uh, Giving them clear information about what is the information that you can expect versus how will it help? I think somebody will have to, okay. All right. So setting up expectation from the test in terms of what can they actually expect and what can they do with those test results. Looking at the time frame, especially in a prenatal setting, is again so important. Second, informed consent based on, okay, we are doing this test, these are the outcomes that you can expect, and here are the limitations, here are the advantages, and do you still wish to go ahead and get the test done? So again, here there was no evidence of informed consent, and I actually went back and looked at the test request form, right? So the informed consent page was from the patient side was just empty. There was no informed consent put in there. So I think this is something that can land all of us as genetic counselors and also labs in big trouble if should a patient decide to go the legal way, right? We can go to the next one and the next one. Yeah. So I think here the most important thing is the impact of this result on the entire family, as opposed to especially with on call a finding with respect to a cancer risk is something that is bound to shake up everybody, right? So breaking up this information, also informing the family that there are a few ethical issues, these are some of the ethical issues, and then at least during your session gaining consent and noting down that okay, this has been explained and they understand this, because it is in a way consent from the parents about how do we proceed from here. And even though they were referred only for post-test counseling, what are the next steps? And that it would involve maybe few other sessions. Now, coming to psychosocial issues, obviously there was a lot of anxiety because the whole reason for them even pursuing prenatal diagnosis is to understand the risk in the current pregnancy. And so they felt like there was a sense of, we did this, we spent so much of money. And this is a statement that the woman said, right? I, as a mother, I have gone through this invasive procedure, which was not easy for me. It was difficult, and there's so much of uncertainty. And at this point, I feel like it has all gone to waste and it hasn't helped us at all. We are not in any different position from where we started, right? The next is with respect to lack of trust. I think this is something that Dipanjana also brought up, right? We build rapport with the clients during the pre-test counseling session. We establish a sense of a psychodynamic relationship with the family. And so they get to a point where they trust us. In this case, because they felt like their doctor had not properly informed them of why the test is being done, they didn't trust the doctor. They didn't want to go back to the same doctor. Now, this is again a conflict that comes up where we have to take this up as a discussion with the doctor so that this doesn't repeat a next time. I think a lot of the times we don't exercise this role of a genetic counselor often enough, where there are concerns and where our role as patient advocates don't come out in the forefront. We just go ahead with, okay, doctor has asked for this, we'll just go ahead and talk to the patient about this. But this is one of those cases where explicitly you are required to stand up as a patient advocate, make their case on their behalf with the referring doctor, so that the patient also knows that, okay, these sort of things happen, and that the doctor's intentions were right, and that we are all a part of the same team, and we are rooting for them, and we are here to support them in this journey. um, we can go to the next one. Dealing with the possible outcome, and this is specifically to do with their own risk for cancer. And in this case, what happened is, because the child was otherwise doing well, he was in undergoing behavioral therapy. They decided not to proceed with any testing with that child at that moment, because they were just so overwhelmed with everything that was going on. And I had to tell them that, that's perfectly fine, that's perfectly okay. You create a timeline that is okay for you. Your concern currently is the pregnancy, is the baby okay, right? So it's important to help them come up with a timeline that works for them. And there isn't really a right or wrong way in situations like this. The only way is the way that works for the patient or the family. And I think we as genetic counselors need to support the families with this. And last is dealing with the incidental finding. And how do you cope with that information? How do you break that information with your extended family, and asking these questions about, does anybody have a risk of cancer? It's quite daunting, and a lot of the times not welcome, to be honest, in Indian families specifically. All right, we go on to the next one. Unjustifiable guilt and fear. This is particularly from both the husband and the wife, because they felt like this is possibly something that they have passed on. And again, over here, as soon as they got the report, they had the report with them for about 3 weeks before they actually got referred to meet me for a genetic counseling session. So they actually went online, Googled, and found information, and they felt that, okay, this is a risk that they potentially has passed on to their proband. And so there was a lot. It was a very highly emotional session, and so a lot of information giving had to just stop. And it was more about supporting them at where they were at, and meeting them where they were at, regardless of what my agenda would have been for the session. All right. Um, and difficulty accepting new medical information with respect to the proband, also with respect to the family history, with respect to the risk that both the mother and father carries, right? So all of these are minor points that we don't necessarily over the top see. But as you sit in and deal with patients who are in similar situations, you actually will be able to pick up so many of these issues, and glaring at that, right? So I think as genetic counselors, our primary role is not just talking about the medical terminologies, coming up with the medical management plan, but it's a lot also meeting where the family is at, and sharing information that will actually help them, rather than make them feel helpless. I mean, they're already in that situation. And if we can support them in a way that they are able to come up with a plan for themselves, make an informed choice about the care, about what next, I think that's where we need to look at our role as genetic counselors. So overall, one, important to manage timelines. It does not matter what the doctor, what the referring physician, or whoever is referring the case to you, whatever is required of you. It's important to look at the timeline based on where the family is at, and use the medical information you have at hand, use the family history that you have at hand, and then work with the medical team, because genetic counselors at the end of the day are a part of the extended medical team. Ordering the appropriate tests at the right time is important, and it's important to also inform physicians who you work with should you come across a case like this. Help the family's understanding of the testing outcome, and provide the family with psychosocial support and appropriate referrals. So this family was actually referred for supportive counseling, because they were just so anxious and highly strung. So there was anger, there was anxiety, there was immense grief in not knowing how to proceed further. And so, like Dipanjana said, I did make a referral for them to meet a grief counselor and a support counselor. Um, and they actually were quite open to talking with a psychologist. And most important, document every single session that you have, every conversation that you have with your families, with your patients, with the doctors, referring doctors. And this helps as evidence not just for us, but the extended medical team, extended laboratory team, should a legal case come up. So I think I've taken a lot of time. I think I'll wrap up the case saying that sometimes it's not obvious, it's not as plain as what we see on a referral letter. It takes a job is to really dig down to what the issues are and work from there. So thank you so much for this opportunity. And should anyone have questions, suggestions, comments, drop them on the chat and I'd be happy to take them or look at them at a later point. Over to you,
We
Nidhi.
thank you, Nivi. It was a wonderful case, and I think highlights some of the very most important points about psychosocial counseling and why we need to really attend the patient and really meet them where you are. So I think you make a very good summary with that point. I'll hand over to the Pranjana for your next case, and I'll just share the screen in a sec.
Hi.
Neerja, could you I'll introduce the Panchna ma'am, if
Yes,
you could.
go ahead.
All right. Thank you, Nivi, for the wonderful presentation. Our next speaker for the day is Dr. Dipanjana Datta. Dr. Dipanjana is a BGCI Level 2 certified genetic counselor and has 14 years of experience in the field of human genetics. She is the West Bengal coordinator for Organization of Rare Disease India and also an invited member in the state of West Bengal Rare Disease Task Force. Dr. Datta did her Masters of Science in Biochemistry from Calcutta University and completed her PhD from Indian Institute of Chemical Biology, Kolkata. She was a past doctor fellow from Oregon State Health University and Virginia Commonwealth University. She has published in numerous international journals of repute like PNAS, Journal of Neurology, PLOS One, International Journal of Gastroenterology, Kidney International, etc. Dr. Datta also holds a patent on in discovery and validation of new biomarkers for metastasis in head and neck cancer along with other members. Over to you, Dr. Dipanjana.
Thank you, Vaishnavi. Thank you, Neerja. And thank you, Nibi, for such a wonderful case discussion. So the cases which I will be, Neerja will be presenting and I will be talking, I have purposely not gone into the diagnosis of the cases because I felt that right now at the current moment, with whatever resources we have, like all of us, we are very mechanical in becoming and suggesting tests, and the very essence of why we are doing genetic counseling is lost. So I have absolutely not presented this case as how I have diagnosed or what are the pointers for diagnosis, but I have presented the case as more of a psychology from the psychosocial point. So if you're interested, there are actually numerous papers. I have highlighted one. There are numerous reviews like this, which if you read, you will understand that the basic role of a genetic counselor, rather than just suggesting tests, is or just being genetic educators, just going on through the information and all. We have a lot more to do. And at every stage, like Nirja presented a Nibi presented a preconception or a prenatal kind of a case. This is a case when you are dealing with adolescents. Obviously, many of you would be counseling, and I have 2 or 3 cases over here where I have mentioned where I am dealing with an adolescent. So if you can go to the next slide. So maximum you will see that there are this particular girl, that I present here 2 girls actually. One is SB. She's about 19 years old, and she's a very radiant girl, and she comes up with hypermobility syndrome, and we actually get a particular mutation. We do segregation, and we come up with the fact that she has vascular type EDS. Now, you understand that in a family, a 19-year-old, she's at that time got through DU, and she is very concerned as to how her life will be and what her life will be. Because obviously, if you read up whatever information you have on vascular EDS, no matter who counsels you, you will feel not only anxious, and people with these kind of syndromes have very high level of anxiety and depression, and it's something which is a part of their the part of their condition. So once we did her, we had very long chats. Even we had chats regarding, like, diagnosis was final, that's fine, but then what comes after the diagnosis? So she had very specific questions. Her first question was that, what should I choose as my career? I got through DU. I have she got in two places. One was psychology and one was biotechnology. Her first question was, do you think that this would have any effect? Her second question was, do you think I will have children? Her third question was, wherever I go, I am being victimized. Her fourth question was, I take more time to write than my peers. I take more because I have a lot of pain. I am sometimes in so much pain that my teachers feel that, I'm acting out, like I'm finding an excuse. So see, her anxiety and everything, her parents were very welcoming. Her parents were the one of the very model kind of parents, supporting their daughter in every decisions. They were very concerned she going off from Calcutta to Delhi and living alone with a vascular EDS. But she is a very confident kind of a girl. She wanted to do it for herself. But here, the reason why I bring up these is that um, your role as a genetic counselor does not end in the diagnosis itself. The second case you can see presented similarly. So she's actually a friend of this first person. She comes up with like, she has no history of developmental delay or scholastic problem, but she has a lot of fatigue, bruising, and she has this pain that won't go away. Actually, because of that, they had connected online, and they were and the first girl, I'll call her SB. SB told, the second girl I will call AD. So SB told AD that, I am having these problems, why don't you see somebody? And AD said that no one believes me, neither my family, none of my doctors, nobody believes me, because they feel that, I am just acting out. And when that happened, again, we made a diagnosis, and the diagnosis was proved, etc. First thing that happened was, her parents said that, this is all something which is not related to us. We cannot have a genetic issue, because in our family, like, you or me or your father does not have this. So there was no acceptance from the parents. Second thing that happened was that, because of that, she went into severe depression. But at the same time, her first response was, thank God, at least I know the reason why this is happening to me, and thank God I am not insane. And when, with this report, she went to her neurologist in Delhi, the neurologist also supported her. So she's found support outside her family. Her family did not support her. They did not want to believe. But because of that, she started going into depression. This is something she had written on the Facebook. And she has these huge mood swings. If you go to the next slide, one point of time she believes that, like, if you just press one point of time, because when you are fighting such things for long at the age of 18 and 19, the age itself and the anxiety of the disorders makes you in a very, very vulnerable zone. So as genetic counselors, the pre-test, post-test, it does not end there. It needs to go further down. As Nibi pointed out in the first presentation as well, you need to be a patient advocate, not an advocate. You need to be there, one of their family member who is neutral. If you cannot be that, then there is a problem. Why? Because when the day I saw this on her Facebook, she was on my Facebook. So the day I saw this, I just texted her on the Facebook and said, what's happening? And she was like, no, sometimes I feel so down. I feel, my own parents don't believe me. Then how am I to lead my life? Like, in further. So here I said, are you seeing the psychologist? She said, yes, I am, but I am somehow not being able to handle it. The fact that I have there's so many things. I want to have kids. What will happen? I'm feeling so anxious. So at that point, you ask them to take one day at a time. I asked her, how can I help you? Do you want me to write to your like college? Do you want me to speak to your parents again? Do you want me to speak to your doctors who are treating you at the point? So if you just look at the next, just click once, like twice more, I would say. So you can see that just a bit of pep talk, just a bit of talking them through to certain stages can change the mood. So I actually issued certain letter. I issued this letter to most of my adolescents. I write to the school, I write to the college that this is the condition. If you want me to go and speak to you or over the phone, I am willing to do that, but you need to give them certain amount of discounts, or you need to give them more time in finishing their assignments. You need to give them more time. You need to excuse them from classes and supply the class materials back, if because they might not, it's a disease which you cannot see. It's a disability which you cannot feel, but not many people know about this. And it's like, even like in a normal setup, if you ask a school teacher, in India, people are not even equipped to pick up dyslexia in many places. So how will they know such a rare disorder? The information, the awareness is not there. So as genetic educators, your raising the awareness does not end at the post test. It goes further. Yes, referrals to clinicians are very important, but the social measures, you cannot go and you say that you don't have anything over here. You need to actually go ahead, and you need to go like go in the social sector, ask them where they are having problems, and speak to the other people. So it's also about awareness. Certain disorders will have certain behavior issues, and if you understand those behavior issues, you need to actually refer. There's very nice paper which actually says that there is a hereditary component because of the genetic issue. And also, like, if one day somebody comes and tells me that I have a BRCA mutation, I will also be anxious. It's like a ticking time bomb inside me. So I don't know what, and whatever we don't know, the anxiety issues can take up more, like can become more become problematic. Next slide, please. So also, here when you are using your counseling technique, so the first thing which we used, if I again use it, it was probably a holistic or a humanistic approach that we were using. In this case is again a diagnosed case of epidermolysis bullosa, but this girl feels not confident in her own body. Now understand, nowadays just a person being fat or a person being too slim, not having the right body, we are so conscious, and this is a girl with scars all over her, not the perfect hair. So how do you comfort her and the family members, because they are very concerned? So you give them examples. So in these cases, you actually probably start CBT. The psychologist will start CBT, but you start CBT right here when they are seeing you at the post-test counseling. What is CBT? CBT is cognitive behavior therapy. So because they already trust you, you already have established something, you need to sort of channelize their emotions to positive thoughts. You give them positive examples, you give them positive validations, you talk about Frida Kahlo, you talk about other people where beauty is just skin deep, and probably they have a personality where they can actually win over. So next slide, please. And you understand that for the family, expressing the line of thoughts like ye hone wala hai, these are what will happen, also helps, because their anxiety level goes down. They know what to expect. So something which is unknown, say something, these are what is going to happen. So always give handbook. So again, you as a patient educator, a family educator, also the start of the psychological counseling, so that they go to a psychologist. The CBT starts right at your counseling session. So then there is this issue where over anxious parents, say this is a carrier with of hemophilia, and she has a 15-year-old daughter she wants to test. it's your ethical duty to say no. What will happen at 15 years? Why do you need to know that your daughter is a carrier or not? Is it an information that will change anything at this point? No. If it is not, then why test at this age? Why not at an age where she can consent whether she wants to test or not? She might not want to have babies at all. So knowing that the carrier status is absolutely redundant to her. So you need to stand up also and understand the genetic liability and the ethics while you are suggesting tests. The next slide, please. So the reason being that just testing, even when we are testing, the family members, many a times I see many of us, even including me, we write test the sibling, test the brother, test the sister, but what impact would it have in the family? So there are actually psychosocial impact studies which are done, not in India, outside, but you need to read them carefully to understand the genetic liability you are having when you are suggesting such tests. Are they open to such tests? Are they consenting? Is there accent and consent for such tests? This is something which you need to understand. Next slide, please. So again, this is something which I already discussed. The CBT, this is a CBT basic slide of a CBT, where your thoughts are channelized into emotions, which are channelized into behavior. So cognitive behavioral therapies, which actually help us to think in a positive way. CBT is something which we can all do in our daily lives. Next slide, please. And there, when you are in a post-test counseling, just don't end it saying that, oh, this is a pathogenic one, oh, this is a likely pathogenic one, oh, this is a VOUS. Understand that the person you are saying to is a human who is not from the medical field or from the medical field, but that person might have their own things to discuss. Like they should leave, either like they should leave, maybe not at that point, but at least they should have an acceptance of what you are saying, and you should understand their problem, rather than being like we say it's non-directive, but how many of us are following this non-directive? They might want to end a pregnancy which you are logically thinking no, they can keep the pregnancy, but they are saying no, I don't want it. You need to support whatever their decision is, whether you like it or not. So it should be goal oriented for that particular person, like that particular family, not for what you are thinking, which what is correct and what is not correct. So non-directive, definitely. Humanistic, definitely. CBT, definitely. But also understand that in doing all this, you shouldn't have any you shouldn't exert autonomy. The only thing which you should exert is that you should establish a psychodynamic relationship, so that whatever they decide, you can tell that these are the consequences of your decision, and if you decide the other way, these are the consequences, in a very neutral way. There are many people in India who ask, madam, what would you do in such a situation? My general answer is, I am not in your situation, neither financially nor emotionally. Neither I can understand how important this is to you, because this will vary. Because it's not that if I have 3 children and my 4th children, I can just go and terminate. That 4th child might be very important to me. So it should always be about that family and not about you. It should never be about you. I think I will open this for discussion right there.
Thank you, Dipanjana, for such a lovely case. I think your point about 2 things that stick around. One is, the ascent, especially when you're seeing adolescent, and I think all of us, I remember just recently seeing, I think I told you about this, about a child, he's not a child, he's a teenager, 18 years old, got tested for epilepsy. He's presenting with juvenile epilepsy now. And he looks very suspicious for JME, and the father is, the person who's really going through the entire session. This is a guy who's in 10th grade. So I actually had the father say, where's your son? He's going through the testing. Why are you sitting in for the counseling alone, right? So he brought in his son through that. And then I had to kind of go over all the information again with the child to make sure that he's on board and he understands the risks and the benefits, and he understands the reproductive implications later in the future. And these kids, this generation are so smart, they already know biology, he's already looked up all this information. So he is, I think the father was more unaware about everything as much as the son, the patient himself, the proband is concerned. He was very much on board. And understands the uncertainty, understands what's going to happen with the information. And I think part of it is we are very overprotective as a parent, where we try to say, let's not tell the child, they're going to get anxious. But really, it's the sense that becomes so important in these cases, because you may be doing more harm by not involving the proband who's already a teenager and pretty much understands everything that's going on around them, right? So that I think is a very important point of discussion. And second thing that you brought up is about the empathy, and then making sure that we are not counter transferring things that's going on in our lives. It's about the patient, it's about their decision, it's about their values, their beliefs. And I think differentiating how we feel as compared to, or we perceive that how we may understand what the patient feels, but we probably are just mirroring our thoughts and impressions on them and their decisions. So trying to understand ourselves sometimes is also important, and I always emphasize this in our practices is, trying to just sit down calmer, after your sessions and just think about what have you done? Did you at any point mirror your thoughts and your perceptions on the patient, thinking that you understood what the patient believed and, decided? So that understanding ourselves is as important in our practice, and taking the time away to understand our beliefs and our systems, in order to provide the most unbiased counseling that we can. And I think one more challenge that comes along is in India, try. Sometimes the patients are looking for a more directive information, and it's all right to do that, but making sure that we are only reflecting what the patient wants and not saying that, okay, this, to hand them out and say, okay, take this decision. No, it's about, are they in consent when they are making that decision and providing that directive also at that point.
Yeah, so
I have Nidhi, yeah.
I was at this conference, and there was huge talk about F8, F9, because they are available and available freely. Should we do a prenatal? So I when I said that it should be the decision of the parents, most of the clinician was like, no, it is not ethical. So to decide what is ethical or not, unless there's a law which is passed, is not our job. So I might not want to invest so much time or that anxiety that I get a F8, F9. I might be in a rural area. I have to walk for 400 kilometers to get to a center which gives me F8, F9. These are the that should be also appreciated. Everybody might not be in a zone, even if the medicines are available. So somewhere it should be always the autonomy of the family.
Absolutely. Maybe, did you have any thoughts?
No, I think just adding on to what both of you mentioned, right? One of the things, especially when we're dealing with conditions like, say, Muffin with EDS, is to also look at quality of life studies, which will better inform our counseling session, even when we are guiding patients and family members with respect to what can they anticipate, what can they expect. So that's something that, rather than going blindly by what we see on, say, gene reviews or a peer-reviewed paper, it's so important to individualize the session based on what they're presenting with, and talk to them and talk them through what they can anticipate and how this can progress. So that is an important part of being a genetic counselor. That is where our medical role comes in, and that's where you step in as an expert with respect to this condition. So the other thing, Dipanjana, I love that you brought up the school of counseling that you use and what is the methodology that you use. I think as genetic counselors, we need to be well versed with the different schools of therapy so that you can implement them depending on what is required in the counseling session. So CBT might work for certain sessions, but certain sessions you just go by family systems approach, especially in a country like India where we see a lot of patriarchal influences, right? So family systems therapy, narrative therapy, it's important for us to be abreast of these schools of thoughts so that we have the best outcome for our patients. So those are the just 2 points that I had from my side. But lovely case, Dipanjana. Thanks for sharing these cases.
Absolutely, it's a great case. Thank you, Dipanjana.
Hi, Nirja. Gayatri here. I have a question. Can I post it to Dipanjana?
Yes, absolutely.
Yeah. Dipanjana, this was really enlightening. Excellent talk. So in lines with the hemophilia case which you mentioned, can I ask whether, is there a rule that probands above 18 alone have the decision to go ahead with a particular test? Since you mentioned a 15-year-old girl and her father had, had approached you. Sorry. So, is there such a rule that genetic counselors follow, that only those 18 and above are eligible to take a decision on their own, or
Ma'am, as far as India is concerned, we actually don't have any such rules. But if we look at the Western world, then carrier screening, especially in these kind of conditions, it needs to have a consent of an adult or an accent of an adolescent. Now, because she's 15 years old and even if she's a carrier, it does not change anything. Like, say, if the same was Fragile X, then probably testing would make sense, because it is something which has a direct effect. It can have a POF. So you can test. But, logically testing a child at 15 when she's not even of a reproductive age does not make a sense. So it is something that is followed outside India. If you ask in India, it has no rules, and I somehow follow the ACMG or the European guidelines in these cases. When there is no rule, it's better to follow, because medico-legally also they will look at guidelines which are existing rather than even if there is no Indian guideline.
Right. All right. Thank you.
Yeah, and I would just add on to it. Even when I practiced in the United States, we, even if it was in a sense, the teenager had to sign the TRF as along with the guardian or a legal guardian or a parent. So their consent and their presence in the counseling session, pre and post test, was mandated. So this is just something that I think we've all continued to practice now.
Thank you, Dr. Dipanjana, for the wonderful presentation. So the next speaker for the evening is Nirja Reddy Maleda. Nirja Reddy Maleda is a board certified by American Board of Genetic Counseling. She has over 7 years of experience in providing genetic counseling in prenatal, pediatric, oncology, and adult genetics in national and international settings. She is skilled in the nuances of reporting of genetic tests as well as counseling psychology. She has worked in research and has expertise in telegenetic counseling. She is currently the Vice President of Genetic Counseling at Mapmygenome and our wonderful reporting manager.
Thank you, Vaishnavi, for a warm welcome. I'll just share my slides in a second. And so I have a case that was, I think, very interesting, and also this something that I connected really deeply with the family, with the couple. So this is a case about, I'm going to call him Mr. A, who at 34 presented to us with an isolated congenital absence of vas deferens or CABVD. And he's married to a fourth-degree relative. They're well-educated, they're settled abroad. And he was actually referred to us from a reputed genetic center in the United States for genetic testing for himself as well as his family members, so segregation analysis. And they are currently, they were in India for a short duration, so they decided to go ahead with the genetic counseling with us. So just to highlight the previous, history, and I think one of the most important things that happens, like in Nibi's case, for example, we didn't get a lot of information. Thankfully, in this case, the patient actually gave us a letter that was shared with their genetic counselors abroad, and it really highlights the fact that you should document really well at every single session. And the genetic counselor who had seen them previously had written a nice letter about what are the next steps that we need to do. So in this current situation, they had already gone through carrier screening, and we knew that both the husband and the wife both were having the same pathogenic genetic change in the CFTR gene. The second CFTR mutation for the male was not identified. In addition to that, the female partner was also found to have a genetic change in JGV2, and they both were planning to undergo PGT for the CFTR. So this is a quick family history. So they're consanguineously married, and his father has passed away with pancreatic cancer in his 50s, but there is no other history of cancers in the family. We have further, done segregation analysis for his mother as well as the female partner's parents, and their respective mothers were found to have the variant that was present in the couple. Just a quick background, and I'm presenting this because I'll talk about why this was important. So we know that CAPVD or the congenital absence of vas deferens is actually quite common in men, and it's about 0.1% of men present with this. We know that most of these people will carry at least one cystic fibrosis mutation, so the CFTR mutation. And we know that there are about 2% of cases where if CFTR is not involved, and there's another gene called CDGRG2, which is associated with a familial X-linked form of male infertility and CAPVD. 10 to 20% of cases with CAPVD, we do not identify any pathogenic variants in the CFTR gene, as compared to people who have a unilateral absence of a congenital absence of vas deferens, will have about 60 to 70% cases where we don't identify any genetic genes. We do know it's quite common for us to see that there is an isolated CAPVD in a male with no other, presentation of cystic fibrosis, and we find that there is a mild mutation because there is another milder allele like a polymorphism in the 5T that presents with some basal activity of CFTR. So, in the West, and also I think with the advances, the workflow has changed. But in the West, especially, the way this was looked at, the workflow was looked at, was that we would ideally do a commercial, kit for the CFTR kit, which has the hotspot variants for men who have CAPVD along with the common, 5T allele. And if there were any genetic changes identified, then they would be sent for genetic counseling. If no changes were identified, then or the second variant was not identified, then they were asked to go through a full sequencing for the CFTR gene. Same for the female partners, they were usually given a residual risk. If only one variant was identified, or if no variants were identified, then they would go through an NGS as in the full gene sequencing. Now, I think with the advancement of genetic testing, we are looking more towards just doing a full gene sequencing for the CFTR. But remember that you do see still a lot of cases where only the hotspots were looked at, whether it's a patient from India or it's a deathly. You tend to see that only the hotspots were looked at. So it's very important to identify what was the genetic testing done, and if it was comprehensive or if there were any gaps missing in this particular case. So in this particular case, obviously, additional genetic testing is recommended because in carrier screening, we usually tend to only report for a likely pathogenic or pathogenic variant. And in this case, we need to really understand if there is a VOUS that is present that might potentially increase the risk of developing, cystic fibrosis in the child, and also if there was any polymorphisms that were present. So, in this case, what happens is the challenges that we are seeing is at two different levels. One, genotypically, what we see is that the mutation spectrum that we see in CAPVD is completely different as compared to what we see in people who are affected with classic CFTR. A lot of times your panels that are designed for CFTR do not include these, non-CF causing mutations which are related to CAPVD. We also see that the 5T variants are more common in the Asian population. And we know that there is a quarter of patients with the CAPVD who do not carry the CFTR mutation. Phenotypically, the result of all of this is that, we end up knowing that there is a mild presentation of cystic fibrosis. Some people may have respiratory issues. Some people may present with risk of developing respiratory problems later in life. There are also solitary kidney, there's one kidney that's present, so there is risk of renal anomalies in the future for some people who have CAPVD. We also know that, it's important to monitor for these. So when this patient came to me, one of the first things that we had to address was, has he been screened? Has there been any test that was done clinically for him? And if yes, then what were those that were performed? So, when we are looking at it from a preconception setting, they seem to be a very calm couple coming in with, with some guidance from an expert genetic counselor. We know that they are plugged into a good system. There are no concerns. But when you start looking at a deeper level, when you start talking to these, couple for a longer duration, we identified that there were two major concerns that they presented with. One was the complexity of this whole thing. On an overview, we think of CFTR to be a simple autosomal recessive disorder. You have two parents who are carriers. The risk is 25% for an affected child and 50% for an unaffected child, for a carrier, and 25% for an unaffected carrier. But when you start, talking to these families who have such cases and such family and personal history, there is so much complexity because you have to do genetic testing at so many levels, even for just one gene, that understanding and wrapping your head around this for a person who is not coming from a science background, let alone a genetic background, becomes really complex. And on the top of that, he had to now explain all of this to his family members, right? Because there is segregation required. So obviously parents are asking on why do you want to do this? Why, what's going to do happen? Like, I'm not having a child. You're the one who's having a child. So what's the point? So we gave them the option of bringing them into a counseling session. And so family therapy is an option in these cases, which is very important because you want to make sure everybody is on the same page and everybody is supportive of your patient, your couple. That becomes really, really important. Um, Second thing that becomes important is the uncertainty. So here, while we know the change, the chances numerically, we know typically we don't know. There is a variability. Even if it's a carrier and it's a male baby, we don't know whether the baby will present with a CABD or not. And this is particularly difficult for the male partner because he on the top level seems like a really nice guy, calm, who's not really feeling any different about his situation. But when we started talking about the uncertainty phenotypically, then he started talking about, okay, is my child going to have infertility? Are there going to be similar concerns? But what about if it's a female? And as we started talking more about this, as the couple started discussing this, and you have to kind of give them space to talk about this individually, and then also let them check in with each other during a session and see how they feel. There were these thoughts that started coming where they felt like if they're going through a PGT that is going to happen for them, they would rather prefer a female child in this situation because they did not, as much as the male said, I'm healthy, I don't have a concern as of yet, but I don't want my son to go through what I have been through. And then there was always the question of why me? Because, there's nobody in the family with an infertility. There's no males in the family with any concerns related to a CAPVD. So then there were questions about why me? Why am I going through this? And dealing with that grief, dealing with that possibility of feeling stigmatized to an extent, feeling like he is the one who's to go through all this testing and he's responsible for this going forward in the next generation. The counselor should be able to address these concerns with the patient, help them understand that, these are normal, to validate these, and also importantly to understand that the perception of risk is really different from one person to the next. So for us on the outside, it may feel like, okay, what, CAPVD is not a big concern. You have ART, there is artificial reproductive techniques, you can do ICSI, you can do a sperm injection. It's not a huge deal, right? Because you're not overall, you can still have your own biological child. But the perception of risk and the burden of that particular medical concern for this male is absolutely different. He feels that this is artificial, it's not normal, it's hindering a normal, healthy pregnancy. And he feels that, I am responsible now for the next generations, and I don't want the same to, go on to the next generation. So the perception of risk in every particular individual and family is absolutely different. And even between a couple, this can vary. So during a session, trying to understand how the male as well as the female feels, and then, the family members feel becomes really important. And like when we brought in, the family dynamics plays a huge role, especially in Indian communities where there's obviously discussions going on at home and how does that influence them, other discussions about, oh, they can't have a normal child because the male has a CAPVD, and what are the perceptions of the family members and how does that affect our couple and our patient becomes really essential in our counseling sessions. So, and then again, the complexity of and the uncertainty that there is a residual risk and that we cannot eliminate because we haven't identified a second mutation. And how do they feel about that? Then that leads to another conversation about, okay, then do we still consider our biological gametes, or should then we consider self gametes, or then should we consider, donor gametes? And then your emotions attached to having a biological child then comes into play. So there are complexities and this uncertainty associated at every single level in such cases, which overall, when you look at an outside case, it just looks very simple and very plain. But when you start talking to the family and the couple and start understanding their perceptions, their beliefs, and the impact of all of this testing and uncertainty on their thought process, there are so many layers, that you can go through and understand. So when you look at, response to uncertainty, obviously healthcare providers, a lot of times, we've seen in research that they may feel uncomfortable providing uncertain results. You may feel that you feel helpless because you can't help them understand what the prognostic, future would be for that particular proband or a patient or a baby that may be coming up in the future. So the patient, it really differs how they, respond to this. It could be optimism. It could differ from, how they feel optimistic about themselves, their life. Also, their tolerance to ambiguity, and also, what is their response to situations that they have seen previously, whether medical or non-medical. A lot of the times, obviously, patients take up genetic testing with the hope of clarity, but often it is, uncertain rather than giving them more clarity. It actually ends up causing more uncertainty in many cases. And each of these testing, while there may be more clarity that's coming up, it may present a new uncertainty. Then, as genetic counselor, during that pre-test, we have to address the fact that sometimes it may be a Pandora's box, and that it may open up things that you did not anticipate. And that anticipatory guidance is a very important factor in helping the patients make an important decision. Um, so what we can do in terms of helping them make that informed decision here is that obviously helping the patients understand, what they are getting into, not just financially, but also with respect to the results, the implications emotionally, medically, and understand really the scope of testing. And if you feel that the patients, we don't always have to do a larger test. We really don't. If you know that the patients don't do well with uncertainty, it might be good call to cut it down and just do a targeted testing and end it there. Because that's what may benefit the patient more than just doing an expanded testing at all times. Which is I think what we're getting into with the cost of testing coming down and with other things that are accessibility getting better at this point. And to discuss with the patient, which is really important, is how did they deal with this in the past? Are there past experiences of ambiguity or uncertainty, and how have they dealt with that? And this is a very important part of your pretest testing because it really helps you understand the psyche of the patient, helps you understand, what their thought process are and how they would deal with it as a family, as an individual. And also give them space to, a lot of times you will find two partners in a couple having completely different ideas, or even responses for that matter of fact, to stress and to uncertainty. To help them bring validate that for each other, bring them to the same place, help them understand that it's all right to have different responses and that we respect it, but at the same time, we have to find a way together to make an informed decision about moving further. Right. So that these are the three, some of the most important things that you want to bring up in a session that can help the session and the people feel that, they have done. As of now, we are still following up with the patient and they're still in touch with us. They're actually going through the PGT process and, they're keeping in touch. The counselor has reached out now with some additional questions and we plan to keep in touch too as they go through the next steps in the process of ART. But I'll open it up for questions for the maybe.
It's such a nice case, and I remember when you were having this case, we were discussing it to and fro. The other thing is also when you are counseling such cases as CFTR, it becomes very difficult because we had brought this up because CFTR even can also have an autosomal dominant form, and this autosomal dominant form in some cases can give benign bronchopulmonary issues. It can also give you pancreatitis. So these kind of things can come up. So when you are saying that a carrier is all right, even with all the testings, you actually don't know because though there's no familial implications, the carrier, the mother does not have any symptoms. But if somebody tells you, can you guarantee that the baby will not have any symptoms? The answer is vague. And as you said, it's all ambiguous. Though we go about by the family studies saying if the family members are heterogeneous and they are not showing any symptoms, the chance of symptoms are very less. But if I am a patient and if somebody tells me that no, only normal is normal and that too also can have a residual risk, so I would be very scared. So here we also need to understand what the patient is going through and actually help him through understanding the situation and sort of give him a correct rather than how do I put it, like forcing him to think that this is like a no way, like, like they have got stuck somewhere. Give him options and give him the criteria that this can happen, this can happen, this can happen, this can happen. And we cannot control all the situations. So we have to take the best call in whatever the situation is. And that is something which becomes very important, I should say. And that can help them to like have a decision which to their liking. And very nicely pointed out that sometimes within the sessions, couples want to decide everything right at that point, because that's how Indian doctors have treated them, that would you want to go for this, yes or no. It is always good to say, please go back, please assimilate the knowledge, please read more and come back later with a decision. Please don't try to take a decision right at this clinic, right at this moment, because you might go back. So this is something which I say when I give a reading material, or when I write my recommendation note, let's see, I told you so much and the information is very new to you. It's something which I sit here and I'm giving all day, but this information is very new to you. You need to go back, you need to read it by yourself, you need to discuss it amongst you and whoever you want to discuss, and then come back and ask me questions and then decide. Decision shouldn't be right at that moment, it should never be, because that's how probably we are like in the Indian system of things. It's like that, this is right now, you have to take all the decisions.
Correct. Correct. Which is very true. It's actually, very well pointed out. Even if this couple, we're still working with them. And like the Panchana said in her previous slides, your sessions really don't end with a pre-test and a post-test. A lot of times you end up following with the family much longer, helping them through the process, connecting and coordinating with their healthcare providers wherever they are. And that becomes a part, you become a part of their system. And that is really, really important for, the benefit of the patient and the couple. And then a lot of times I also find that you have unresolved issues within the couple that comes up when you're counseling them. And it's really important to kind of, put aside your genetics, put aside your numbers, and then just address where they are emotionally, and help them kind of work through that. So I use a lot of motivational interviewing techniques, through my sessions, just keeping open-ended questions, using your body language, using, letting them kind of speak, so narrative therapy. So these are things that I think comes up quite often during your sessions. And like what Nidhi said earlier, we really have to be adept with our counseling techniques and also keep learning new techniques. So recently I also found that positive psychology really works well and it fits in so beautifully in our, genetic counseling system. And so these are things that I think we have to discover ourselves as genetic counselors, collaborate, talk about it so that we are able to serve the best to our patients.
Yeah, and also sometimes you are stuck. Like this happens with me, Nirja, Nibi. We actually talk about, counseling sessions. Sometimes you are probably stuck with your own thoughts, that this is how it should be. But the moment you speak to your fellow counselor, that person might have a very different kind of, approach to it. And that might actually help you to guide that particular family along. Also, the other thing which is extremely important in these cases are the choices they have. You really need to bring in the choices, and even after they have those choices, there can be doubts. Like I'll give you an example of this child. We actually did prenatal diagnosis. The first child had deafness, and you might feel it's okay, deafness is nothing life threatening, but the father was very in this zone that the amount of time I had to spend and anxiety just to make my child talk after a cochlear implant. I am not ready to take that up again. I'm not ready to invest that time or that energy or that anxiety in my next baby. And the mother wanted the second child, but the father was absolutely against it. But when we counseled, he gradually calmed down, and when he actually had a child, he was still in that zone. And after they did the OAE, when we actually established that the child was all right, his first reaction was that, thank God you answered all my questions, because he had these questions. We just tested for this particular gene. What if there is a de novo mutation in some other gene? And these questions are not invalid. but
Absolutely not.
you cannot take control of everything. I remember him sending me papers that first child has a autosomal recessive one, the second child has a de novo one. So if you
Genome.
search, there is so many papers about so many things. But if as a genetic counselor you cannot have that patience, though it's draining, but if you don't have that patience, it just does not end in a like post test counseling. You need to do more over there. And as Nija also pointed out, it's very important to take the like what the man is thinking. He might think, what if my child has infertility? It's not a problem. That is also a decision, and there's no problem in that decision, I feel.
Absolutely. Absolutely. Well, thank you so much for sharing your thoughts and your concerns in this particular case and comments. I would open it up to the audience as well. If anybody has any questions, concerns, feel free to unmute yourself and talk.
Yes, if anybody has questions, you can unmute yourselves and turn on your video so that we can see you while you ask your questions. The forum is now open. Okay, while our audience decide on what questions they should ask, I have a small announcement to make to all the participants. So at Mapmygenome, we are doing preventive genomics. Like, we are one of the pioneers in India to start the preventive genomics. We are giving a 10% discount to all our participants on a product called as Genomepatri, and the code for this testing is GCDAY. So I'll just write out in the chat box so interested participants can reach out to either me or Neerja. So this is just for all the participants who have attended this particular session.
I do want to give my special thanks to the Panchana and Avi for taking out the time today and being a part of this wonderful session. I thoroughly enjoyed it. I hope that our audience was able to, take away a few things from our conversation today. I truly believe genetic counseling is a collaborative effort, and I have seen, I'm sure the Panchana would agree, Nibhi would agree, that we've seen the GC community in India grow and how magnificently we grow. And it's beautifully done. I think we're growing well, and there's so much to do. I do honestly believe that more collaboration would be helpful, would be beneficial, and just having more conversations between all of us, would be really helpful for each of us and also our patients overall in advocating, for the families in India. So I think there's a lot of work that is still need to be done, and I'm sure each one of us, can contribute in big ways towards that. Thank you, Nidhi and the partner, for your time. Really.
So much, Nisha, for thinking this topic. Like, we always discuss cases with respect to genetic testing and all. This is so wonderful to just talk about counseling and not anything else. Also, in doing so, I would like to like sort of draw the attention to all the fellow geneticists here that, while you do such counseling, it is personally draining. So, as a person, you also need to find your, like, I'll say it in this way, that you need to figure out your own shit also. So you have to actually find some way where you will have to, de-stress. It might be like maybe goes out for a lot of shoots and, drives. I go for treks. I also go for photo shoots, like ninja dances. So, you need to have that zone where you feel very comfortable. Don't let this drain you off so much that when you are sitting in front of a patient, you are actually solving your own issues. If you find difficulty, please reach out to a mental health specialist. As geneticists, genetic counselors, it is not wrong to reach out. And there is, even if you don't have any problems, but you feel you are tired and you cannot pull yourself up. So please do go ahead and get yourself tested. There's a question which says,
it's from Ashwini. Dipanjana would like to know, how did you tell about de novo mutation with previous child with AR mutation?
Oh, so see, this was a concern of a parent. So, deafness is normally either a X-linked or autosomal recessive disorder, but there are certain deafness, like genes for deafness, which are also de novo. Okay, so the parents' concern was that we are checking the autosomal recessive gene. We are doing a targeted testing, but what if this fetus has a de novo mutation? Well, when it comes to that, in every counseling or every time the family asks you this question, the answer is only one, that we cannot test for a de novo mutation. There's no way we can test it. It might be a VOUS also, and we cannot test it. So you have to say that nothing is 100%. We can only be sure that probably if there is an established diagnosis in the index child, that diagnosis will not happen again if we are screening under the right criteria with the maternal cell contamination, with everything. But you cannot account for a de novo. That is what is probably a residual risk which we are talking about. So you cannot assure a person, even that there is 100% nothing is going to happen, because it might be a carrier. They might have one mutation there, and the other mutation can be de novo. Any autosomal recessive condition, any autosomal dominant condition can have that, and you cannot go about testing for all those conditions. So your counseling should be solid there, saying that we cannot account for that. That's a risk. That is why when the child is born, you have to go for the hearing screening, and you have to take it as it comes.
So I usually use the phrase never say never in genetics. So you really don't ever know what's going to happen. Good question. All right, then. Yeah, I think call it a wrap.
Ma'am has a question. Yeah.
Yeah, this is a academic question. The curriculum for genetic counseling in India is established by which body? Who sets it?
No one, actually. Every university, whoever has a genetic counseling curriculum, sets their own curriculum. We don't have a national body as of yet. We hope that there would be very soon, but we don't have a national body as of yet that's overlooking these curriculum.
I see. And if at all, yes,
the active body right now is the BGCI. If I'm looking for an organization, it is BGCI. But there is no pan-India, or there's no national body as such. BGCI is also, though we are all sort of affiliated to BGCI, but BGCI is still a body from Telangana. It's in West Bengal, BGCI is not registered as such.
It's registered by the Telangana government, under Telangana government.
Under Telangana, so it's not a national body.
Right. So curriculum development is not the cup of tea, right?
So it's only the certification. Annie ma'am has done it in the place where she practices.
Correct.
It is person-oriented planning of the curriculum, I should say.
I see. And with respect to policies, would it be MCI or BGCI, or is it combination of both? Whatever policies exist as of now.
MCI is not into this. We are BGCI might, but again BGCI is not a national body. So as far as I am thinking now, it should be ICMR. If anybody has to come out with rules, it should be ICMR, because the PCPNDT guidelines, all these guidelines are coming out of ICMR. So if there are any ethical guideline that needs to be come out, it's not MCI, but it has to be either BGCI in a national way, which is registered somewhere, or it has to be ICMR.
So if you want to look up policies, I have to go to ICMR website and look it up.
Yes, and there is no policy there.
Oh, I see. All right.
So for genetic counseling, there are no policies in India as of now that is set up, except the PCP-CNDT, which is obviously applicable for everybody who practices medicine. But what we as genetic counselors in the community, and I think VGCI also to a large extent does, is we do rely on international guidelines, whether it's by ESHC, which is the European Society of Human Genetics, the ACMG, the American Society of Human Genetics, or the ACOG. So these are, and the NFTC, of course. So these are all combinations of, and these are policies that are well set. The only thing I think that challenge comes up is like the workflow I presented in my presentation. It's very much tuned to what practice in United States. That's not true for what practice we do in India. So you can't take everything, you have to take it with a pinch of salt, kind of you tweak it to our culture, to our medical practice, and then, go ahead with it. But the ethic, I think the basic, foundation remains the same. Of course, there's the culture that differs, and so the cultural counseling will differ a little bit, but the ethos remains the same, wherever you go.
Nice. All right. Thank you.
All right, wonderful. Vaishnavi, I want to thank you for moderating the session. Thank you so much for taking the lead on that and being a part of this so well. And thanks to everybody in the audience for being here today despite of being a Saturday evening. Thank you for being with us. Thank you so much.
Thank you so much, Neerja, Dipanjana ma'am, and maybe for the wonderful presentation. I thank all the participants who were there from the beginning to the end, and those because of network issues. I think they're messaging that they do have certain network issues because of which there's a lack. So with this, we've come to the end of our webinar. Thank you so much, everyone. Have a happy Saturday. Have a happy weekend.
Bye.
Bye.
Hi, and thank you so much, Vaishnavi and everyone. Thank you so much.
Thank you. Thank you.
Bye-bye.
Thanks, Natasha. Bye.